All right, we are going to talk today about our concept of sensory and perception. So, when we're talking about sensory and perception, we are talking about our sensations that we know and love, our five senses, and then our perception of them. What information do these sensations tell our body, and how do we react to it in our environment? So, our five senses is where we're going to start. So, we've got vision, hearing, taste, smell, and touch. Um, in addition to those five senses, we also want to pay attention to the sense of our body in space. So, that along with all of these five senses are going to help us to interpret and interact with our environment in a meaningful way. To grow, develop, and function, we must be able to sense and respond to sensory input that we get from our environment. We're going to be talking about a variety of different things when we talk about sensation and perception. We're going to go through sensory overload, sensory deprivation, sensory deficits, and then we're also going to talk about certain things like seizures and how are we going to respond to those things as a nurse. Just keep in mind the sensory system we use to promote our safety a lot of the time. And a lot of these sensations do decrease as we age. And there are also a variety of medical problems that can decrease these sensations for us and really inhibit our ability to interact with the world around us, as well as get those safety cues that keep us safe and our patients safe while in our care. So, our senses are going to give us information about our environment inside and outside of our bodies. So, just remember the purpose of sensation is to allow our body to respond to changing situations with an end goal of always maintaining that homeostasis. That is really our body's main concern and main job, no matter what's going on, whether it's some kind of emergency like massive hemorrhage or even as something as small as everyday anxieties that we may have. Your body is constantly working to balance that out to get us back into a calm state of balance. So, maintaining homeostasis is the end goal, and our senses kind of help us with that. Anytime we're talking about a sensory experience, which can be positive or negative, it doesn't matter. All sensory experiences involve four components and all located in the nervous system. Those components include a stimulus, reception, perception, and an arousal mechanism. We will get into the details of these in here in a couple of slides. So these senses are going to allow us to respond to changes, right? So think back to your first anatomy class you ever had where you talked about your nervous system. I'm talking hand on a hot stove, you pull it away, right? So it allows us to interpret, they allow us to experience that stimulus, your hot stove. And then in 0.0000001 seconds, you're like, oh my gosh, this is hot. And so without any thought, your hand pulls away from that. That allows us to respond to those changes in our environment. Same thing when you go outside and you're like, oh my gosh, it's cold. I'm going to put on a jacket. Or you go into a hot room. I'm going to take off my jacket. So the sensory experience is really leading that cause for us to, again, maintain that homeostasis. And then all types of sensory experiences and having those in good working order, it's necessary for human growth and development. So that first piece of that sensory experience is the stimulus. So there is some kind of trigger that's going to stimulate a receptor. The meaning of that stimulus or that trigger is going to depend on the reception and the processing of that. So a stimulus could be a loud noise, it could be a bright light, it could be a really sour lemon, right? All of those things are going to stimulate that system to react in some way, shape, or form. So, reception is the process of receiving that stimuli from the nerve endings, and in there, those are in the skin and inside the body. That receptor is going to convert that stimulus to a nerve impulse, and it's going to transmit that impulse along those sensory neurons to the central nervous system. Some receptors are activated for as long as that stimulus is applied. However, most receptors adapt to stimuli. So like their response declines with time, right? So adaptation explains why over time you may walk into a room and say, "Oh my gosh, that candle is so strong," or "Oh my gosh, it smells horrible in here." And then you're in there for a little while and you've determined that you've become nose blind to it, right? Because though we are adapting in that way. Same with like noises. You may get used to hearing that white noise as you sleep, and really, you don't even understand that you're listening to it until it turns off. And then you're like, oh my gosh, I didn't even realize that, right? So that's kind of that adaptation piece. Again, all of that, so it really, reception is just the process of receiving the stimuli from the nerve endings, and all of that is going to occur through receptors, right? So we have a lot of different kinds of receptors in our body, and we'll go over kind of what these ones are. So when we talk about thermoreceptors, these thermoreceptors are in the skin, and they are detecting specifically variations in temperature. So the warm sun on your skin, the warm or coolness of a room, those are your thermoreceptors. You also have proprioreceptors. These are in the skin, muscles, tendons, ligaments, and joints. And they coordinate input to enable us to sense the position of our body in space. So are we upside down? Are we floating? Like that's why if you've ever done something that kind of makes your stomach drop, maybe like a roller coaster or zip line or something like that, that may make you feel a little like, ooh, or even like being on a boat for like a while. You get those sea legs, like same kind of thing. So you've got your proprioreceptors that are kind of enabling us to sense where we are in space. And then lastly, you have your photoreceptors. So these are located in the retina of the eye, and they detect visible light. So if you're out in the bright sun, we know that our pupils are going to constrict, and that is a result of those photoreceptors. Whereas if we're in a dark room, they are going to get bigger as a result of those photoreceptors as well. The next piece of that sensory experience is going to be perception. So, perception occurs when the person becomes aware of this stimulus and receives that information. So, it would not be physically possible to process all of the stimuli that constantly bombards our bodies on a day to day basis. The brain actually discards about 99% of all sensory information as irrelevant and unimportant. Your perception is going to be affected by the location of the receptors and the pathway that's activated, the number of receptors that are activated, the frequency of action potentials that are generated, which is going to vary depending on the intensity of that stimulus. A really strong odor or a really loud noise may get more of a response out of you than does something lower on that scale. And then lastly, changes in location, number, or frequency of those as well. The final piece of that sensory experience is going to be arousal. So it's composed of the consciousness and alertness, and it is mediated by that reticular activating system. So that reticular activating system, if you remember, is located in your brainstem. It's going to control that consciousness and alertness, which is how it relates to our arousal, right? Those neurons in that reticular activating system make connections between the spinal cord, the cerebellum, the thalamus, and the cerebral cortex, relaying that visual and auditory stimuli that help keep us awake, attentive, observant, those kinds of things. Without stimuli like that, the central nervous system becomes lethargic or tired, and that person may lose consciousness. This can be affected by lots of things. So it can be affected by your environment. So if you are in a loud concert, you're probably not going to be tired, right? But if you just took a warm shower and you're in a darker room and you're reading a book, you're probably going to be a little bit less alert than you would be at a concert, right? So our environment has a lot to do with that. That also we will talk about a little bit when we talk about sensory overload, because we'll talk about maintaining a dark, quiet environment, because that will decrease the overwhelming stimuli that is kind of a piece of that puzzle. Keep in mind as well, it will also be affected by medications. So there are plenty of central nervous system depressants out there. So anesthesia is obviously going to affect consciousness, right? Opioid drugs is going to be a depressant as well. Sedatives as well. And then you also have some central nervous system stimulants that may increase or make them hyper aware. I know one medication specifically, like albuterol. Albuterol is given for clients with asthma. It's a breathing treatment. But a side effect of that is it makes patients, it makes them tachycardic. So it raises their heart rate. It causes them to be jittery. It causes them to have like a nervous feeling. So drugs like that can also kind of affect this pathway as well. Now, when we're talking about our response to sensations, there's going to be a few factors that are going to affect that response. So, first of all, the intensity of that stimulus. So, a very intense stimulus is going to excite more receptors, leading to a greater response. For example, a super bright, glaring light can cause you to respond by squinting and shielding your eyes, whereas a dim light may cause very little reaction from you, right? Secondly, contrasting stimuli. So, contrast is also stimulating. Imagine being outside in the cold, very windy weather, and then you enter an unheated garage. You instantly feel warmer because that building is going to block the wind. Whereas if you then go into a room with a blazing fireplace, you're going to need to take off layers of clothing rapidly because the contrast in temperature is going to make you feel hot. Does that make sense? So that's another thing. And then third, adaptation to stimuli. So nurses are going to typically become accustomed to the noise, the lights, the activity, even those IV alarms, right? We talked about alarm fatigue when we talked about safety. So that's kind of here. So we become used to those alarms and we're able to kind of tune them out or expect their presence whenever we go to work, right? Well, a lot of times for patients, these things are new. This type of stimuli is new to them, and they're going to have a harder time getting used to that than you would. It's going to bother them a lot more, right? And then also previous experience. So prior experience with a stimulus is going to affect the ongoing responses to that same stimulus. So if you've ever seen a patient scrunch their eyes or grit their teeth or turn away from an injection before you're even ready to get it, this may mean that the patient has some kind of prior memory or trauma or something negative when it comes to receiving this type of treatment. So we have to be aware of that as well. But again, any type of response to sensation requires people to be alert and receptive to that stimulation. So you may also see that a response to verbal stimulation is not going to work on a patient who may be unconscious or heavily sedated, right? But those same patients may respond to a painful stimulus, whereas they wouldn't respond to a verbal stimulus. So your patient's level of consciousness plays a role in this as well. All right, got a clicker check here. So the client who has had a stroke states to the nurse, I can't even tell where my left leg is. This reflects a lack of response of stimuli by the what? Mechanoreceptors, proprioreceptors, thermoreceptors, or chemoreceptors. The answer is B. The stimuli gathered by those proprioreceptors enables us to determine the position of our bodies in space. So now we're going to talk a little bit about some sensory alteration. So we're going to talk about sensory deprivation. So what happens when we're not getting a lot of sensory input from our environment. We're going to talk about sensory overload when we're getting too much sensory input from our environment. We're going to talk about sensory deficit. So this is like your impaired hearing, impaired vision people with maybe need glasses or hearing aids or things like that. And then we're also going to talk about seizures. All right, so sensory deprivation. So what is it? So it is a state of that reticular activating system that we talked about, where that particular system is depressed, caused by a lack of meaningful stimuli. So when environmental stimuli is deficient, the remaining stimuli, such as distant noises, minor pain, cold extremities, those things can become overly noticeable or distorted to the patient. It fills in that sensory gap and causes the patient a level of distress that seems out of proportion to the intensity of that stimulus. It can seem as though that patient may be overreacting but really they've just been sensory deprived. So it just seems so overwhelming to them in that moment. This can be anything: visual, auditory, olfactory, tactile deprivation, all those things. Okay. Risk factors for these patients: are they bedbound? That's going to have an effect on that. In critical care can increase their risk, and then also on isolation. Even we're talking isolation in a healthcare setting, but if you think about people who are in like jail or have to go to like solitary confinement, things like that, you truly do get that sensory deprivation, which is truly can have a detrimental effect on your mental health and your physical health as well. And then signs and symptoms of this. So irritability will be a for sure one, right? A reduced attention span, delusions, hallucinations, and then decreased problem solving skills as well for these patients. So, my favorite statement in nursing: what are you going to do about it? So, let's talk about that. So, when we talk about someone with visual sensory deprivation, what things are we going to do to help promote that sense of well being to them, make this a little easier for them? So, we're going to help them put on their glasses or their contacts or whatever visual aid that they have. Also, we want to make sure that those things are clean. So clean them for them. Let's not let our patient run around in dirty glasses. We're going to put photos on the walls, decorate their space, put some flowers on the table for them to see, put up on display maybe some old birthday cards that their family sent them, things like that to make them feel surrounded by love in their environment. We're going to open their blinds for the day. We're going to say, hello, it is a beautiful morning outside. Here, let's enjoy looking out the window, so that they're not in a super dark room all by themselves, deprived of any type of outside environment. And then if it's an auditory deprivation, we're going to help them put their hearing aids in the morning. We're going to make sure that their batteries are charged, make sure that that volume is adequate. We're going to move to a distraction-free environment when communicating with them. We're going to speak directly to their face. That's very important with patients with hearing problems, to make sure that they can read your lips, because a lot of patients really focus on that. And then also we're going to facilitate communication with a whiteboard or a picture board if we need to. And now let's talk about sensory overload. So what is it? So when we're talking about sensory overload, this is when your environmental stimuli is going to exceed the ability of your body to adapt to it. So this happens especially when all of that stimuli is persistent and non-meaningful. So we're talking about monitor alarms. That IV thing is beeping. My blood pressure cuff is beeping, beeping, beeping. If there's a paging system overhead. Interruptions in sleep by healthcare workers, if we keep coming in every half an hour to get a blood pressure while they're trying to sleep. Certain medications like stimulants, albuterol, like we talked about earlier. Caffeine can be one as well. And any other types of sounds, smells, or even pain. If pain can cause that sensory overload as well. So signs and symptoms of this: irritability, once again, okay? If anybody's ever been overwhelmed, like I have too much, too much going on right now. I know we've all felt like that. That is sensory overload, okay? So irritability for sure. Reduced attention span, confusion, inability to concentrate, and decreased problem-solving skills. So very similar to your sensory deprivation patients in regards to the signs and symptoms. And once again, what are you going to do about that sensory overload patient? So we are going to minimize any unnecessary light, especially at night. So closing your patient's door, making sure that their light is off, should they prefer it that way, making sure that their blinds are closed if they want them that way during the day or at night for sure. Making sure that when we're coming in the middle of the night, if we have to do something, that we're not turning on every single overhead light in there. Let's use a flashlight or one of the smaller lights or something, so that we can minimize that sensation for them. We're also going to minimize unnecessary noise. Make sure that we follow up on alarms should they go off. Minimize their noise, or stay on top of the things that we need to do to where the alarm doesn't necessarily need to go off, right? Reduce noise levels at night. Again, shut their door if they're not a safety hazard and they can have their door shut. We're going to speak in a calm, confident voice. And then consider earplugs. Maybe earplugs could be helpful for this patient. For these patients who maybe at a higher risk for this, maybe recommending that they turn off their televisions in their room. Maybe it could be helpful for us to be on the lookout for family members that are maybe overwhelming to the patient and step in and ask them to leave should the patient agree to that, to give the patient some rest. And then, most importantly, all the way around, cluster your nursing care. If you know that you have a medication due at 11 p.m., maybe let's do our vitals at that same time as well. Or if we have some labs that need to be drawn, let's try to do as much as we can at that time that's due so that we don't have to wake them up every hour to do something new. Cluster our nursing care, and then that way we just have to worry about our safety checks where we peek in on them every 30 minutes to an hour, depending on our facility policy. Some examples of some sensory deficits, which is what we're going to talk about now. So these are some visual deficits. You do need to know what all these are by definition. I'm going to go over them. You will need to know them. So myopia, this is also known as nearsightedness. So these types of people, like this particular condition, they're going to see close objects well, but not distant objects. Hyperopia, which is your farsighted people. So they're going to see far away objects well, but not ones that are close. Then there's presbyopia, which is a change in vision that's associated with aging. As the lens becomes less elastic, we can't show near objects nearly as well. So presbyopia, age-related visual changes. Okay. Astigmatism, this is an irregular curvature of the cornea or the lens that is going to blur the image onto the retina. Then there's cataracts, clouding of the lens. This results in blurred vision, glare, and a distortion of images. Glaucoma, this is one as well. So this one is actually going to be increased pressure in the anterior cavity of the eye that is going to cause blurry vision with halos around some lights and is going to result in a loss of peripheral vision. So that vision you see out of the sides of your eyes. And then without treatment, glaucoma will lead to blindness. Okay, and that picture that you see there, that is an eye with glaucoma. And then macular degeneration, which is a loss of central vision as well. Okay. So all those on the previous slide were visual deficits. All of those things are going to cause a decrease in vision for the patients that have those conditions. Now we're going to talk about some auditory sensory deficits. So conduction deafness, this may be temporary or permanent and can be caused by things like an infection of the middle ear, a punctured tympanic membrane, earwax impaction, a foreign object, etc. Hearing aids will help with this type of hearing loss. So conduction deafness can use hearing aids. Sensorineural hearing loss, this is nerve deafness. This happens when there's damage to cranial nerve 8 from ototoxic medications such as gentamicin. It could also be caused from trauma. There could be hereditary causes, bacterial or viral infections can cause this as well. Just keep in mind when I say ototoxic, that means toxic to the ears. So gentamicin is one of those medications where if it's given in too high of a dose or over too long of a period of time, hearing loss can be significant from that drug. When we're talking about sensorineural hearing loss, hearing aids may not help in this type of hearing loss. Then there's presbycusis, which is a progressive sensorineural loss that occurs with aging. This occurs from deterioration of the hair cells in the cochlea, which is actually what transmits the sound there. And then also tinnitus, which is a ringing of the ears. Most tinnitus comes from damage to the endings of the nerve in that inner ear, which can be caused by trauma. If they have something called Meniere's disease, that can cause that as well. Hypertension, so high blood pressure, ear infections, and then there's certain medications as well that are known to cause tinnitus. Those medications would be aspirin. That is a huge one for tinnitus. Lasix, and then gentamicin as well, which is that ototoxic medication we talked about already. I want everyone to memorize this slide because it is super, super important for you to make the connection between sensory deficits and a safety issue and a safety hazard. Okay. Anytime you have a patient with a sensory deficit who wears glasses or hearing aids or cannot or is immobile, like all of those things should trigger you to think safety problems. Okay. Sensory deficits can be a significant safety hazard. Safety is your number one concern with these patients with sensory deficits. So, what are you going to do about it with your sensory deficits? So, when we're talking about someone with a visual deficit, we are going to keep their bed in a low position. All of these interventions here are going to go right back to that safety concept. Okay. Keep that bed in a low position. Okay. We want no throw rugs, no scatter rugs. Any of those rugs that you see that, if you ever step on it and it kind of slips and slides, those are super, super danger for people with sensory deficits, but also just the older population in general. They're a safety hazard and you should never ever recommend them for these types of patients. So no throw rugs, no scatter rugs. Keep the room free of clutter. We don't want people tripping over stuff as they're trying to walk when they got their glasses on and all that stuff. We want to make sure that their room is free of clutter. Always make sure that their eyeglasses are on or within reach. If they can't put them on themselves, that's our job. We always want to make sure that they're clean as well. Clean them off for them, place them on their face. Always make sure that they're in their reach, though. If you're not in the room and they need their glasses to get up to go to the bathroom, they are going to need to have those within their reach. And then always keeping their call light within their reach as well. And then for patients with auditory deficits, a priority for this patient is going to ensure that their hearing aids are in their ears if they use them. Okay, if you ever have a patient who has a hearing deficit, before we talk to them, before we send them out of that room into somebody else's room or into like a dining room or wherever they may be going where they need to interact with others or interact with their environment, they should have their hearing aids in. That is a priority. Another thing, we want to make sure that we're inspecting their ear canals for cerumen impaction, otherwise known as earwax, right? We're going to ensure the hearing aid batteries are charged and that the volume is set and acceptable. And then we're going to provide written instructions if needed for these patients. And lastly, we're going to speak a little bit about seizures. So when we talk about seizures, a seizure is the abrupt onset of a disturbance in electrical activity in the brain. So essentially, a group of neurons is going to fire abnormally. Okay, this results in motor symptoms such as rhythmic jerking of the limbs, arms, and legs. In addition to motor symptoms, the person may have a decreased level of consciousness or a total loss of consciousness. Symptoms and the duration of the seizure are going to vary depending on the area of the brain that's affected. A seizure can typically last from a few seconds to more than 5 minutes. Most of them last less than 3 minutes, though. There's multiple different types of seizures, and they are described as either generalized or partial is typically your two umbrella categories. So the difference between these types is in how and where they begin. So when we're talking about a primary generalized seizure, this is going to involve widespread electrical activity on both sides of the brain at the same time. So most commonly, this type is caused by some type of hereditary factor or low levels of anti-seizure medication. So think epilepsy when we're thinking about primary generalized seizures. Okay. And then there are partial or focal seizures. These are going to begin with electrical discharges from one side in a limited area of the brain. So common triggers for these is going to be ingesting some type of mood-altering substance, on the street drugs. Could be infection of the brain or the cerebrospinal fluid, so maybe like meningitis, a tumor, any type of like head trauma, sleep deprivation, stress, illness, and even hormone fluctuations sometimes during puberty can cause these. Sometimes there's no cause that can be identified, but those are the two different types of seizures. Symptoms of seizures, we're looking at rhythmic jerking of the limbs, so arms and legs, and then the decreased level of consciousness and sometimes absence of consciousness. So again, you definitely need to know this about seizures. All of this stuff about seizures, super, super important. Triggers, like we talked about, again, you want to know these. So sleep deprivation is a big one. Stress, illness, any type of hormone, so menstruation in females and then puberty in general, both sexes. High fevers can trigger a seizure. Typically, that's going to be in your younger kids from 3 months to 6 years old, but febrile seizures can be a thing. Bright flashing lights for people who are sensitive to that can cause a seizure. And then stopping an anti-seizure medication abruptly. That is huge education in nursing. We never, ever, ever want anyone to stop their anti-seizure medication abruptly. They always should be tapered off slowly, and they should never stop it on their own. Complications of seizures. So it could be respiratory depression. We always want to make sure that we're prioritizing the assessment of that airway during a seizure. So respiratory depression can happen, and it can happen quickly. Tongue biting, that's another complication that you'll see a lot. And then there is a stigma to having seizures and some anxiety as well. If you know that certain things are going to trigger your seizures, or you could be embarrassed that you're going to have a seizure out in public. So they may isolate themselves just out of fear of that. So all of those things can happen to these patients who have diagnosed seizure disorders. So the specific types of seizures, we've got your tonic-clonic seizures, or otherwise known as grand mal, they used to be called. These are going to be the ones that you see rhythmic jerking of the limbs with general body stiffening, loss of consciousness, loss of bowel and bladder control. And then you have your atonic seizures. So this is going to be a sudden loss of muscle tone, sometimes also called drop seizures. And then your absence or your petit mal seizures, which is a brief disconnection, such as a blank stare or your eyes rolling back in the back of your head, those kinds of things. And when we're talking about our nursing assessment, so first and foremost, we want to assess for any type of triggers. What things happen to you before you have a seizure? Is there certain things that trigger it? Some people will have an aura before a seizure. They may smell a certain smell or see a certain visual effect or something that lets them know, like, oh no, I'm about to have a seizure. We want to make sure that we're educating those patients. If you happen to experience your aura and you know you're about to have a seizure, please sit on the floor or let somebody know so that we can be there for you and reduce injury. That is really our main goal as nurses, and really even as lay people out in the community. We want to be able to prevent injury. That is our biggest goal. So assess for triggers. We're going to also assess the airway during and after. Again, airway is huge when we're talking about seizures, so that is a priority. We're going to observe for nystagmus. So we know that nystagmus is that rhythmic kind of jerking of the eyeballs where they're kind of going back and forth, back and forth. We're going to assess for drooling, confusion, and breathing quality. And then once the seizure is over, we're going to look at post-seizure activity. So motor function, consciousness, the ability to speak, memory, and orientation. Typically, patients are very lethargic after a seizure. This is just a little visual for you. You can see here at the top at letter A, that's going to be your tonic phase of the seizure. You can see letter B is the clonic phase of the seizure. And then letter C is going to be your post-ictal phase, which just means post-seizure. So post-ictal means post-seizure. Again, typically very exhausted and tired. They sleep for hours and hours afterwards. And then our most important thing, what are we going to do about it when our patient has a seizure? So our priority intervention during a seizure is to maintain a patent airway on the patient by turning them to the side. So when we turn our patient to the side, we allow for their tongue to not go to the back of their throat and block their airway. We allow it to kind of hang out the side of their mouth, which is what we want. Same goes for any drool or saliva that they may be, or even vomit if they throw up during their seizure, anything orally that comes out of their body, we are making sure that it's coming out onto the ground like during the seizure by turning them onto their side. If they were on their back, if we left them on their back, they could choke on that or aspirate it, and it would just cause more harm than anything else. So rolling them to the side, priority. Assessing their airway, priority. And then continuously assessing the patency of that area during and after the seizure. So before a seizure, when we have a patient who comes in and we know that they have seizures often, or maybe they have something going on that puts them at a higher risk for seizure, even if they've never had one before. So let's say they have a low sodium level, that can put them at a high risk for seizures. Those people may be put on seizure precautions. Same with a patient who may have preeclampsia, who's in labor. They are at a high risk for having seizures, so we may put them on seizure precautions. It's all about assessing for that risk, and then let's put these safety things in place that's going to minimize harm should they have a seizure. So what are we going to do about it? Caring for that client with a history of seizures. First thing, we are going to establish IV access. We want to have that IV access should we have to give them some anti-seizure medication. If they start to have a grand mal seizure for like 5 minutes, that would be an emergency. That's a long seizure. So we want to have the IV access so that we can give them medication if we need to in that moment. We're going to ensure the bed has full-length side rails, and we're going to make sure that they are padded and pad the headboards with blankets or padding so that they don't, should they be thrashing about during a seizure episode, that minimizes the risk for injury to them. We're also going to make sure we have suction equipment at the bedside. Should they throw up during a seizure or should they start to choke on their own saliva, we want to have that suction equipment available to maintain that patent airway. And then airway equipment as well. So an ambu bag, oxygen, intubation supplies, all of that stuff. Another couple important things we want to pay attention to is if we know our patient is at risk for seizures, let's see if we can get them a room really close to the nurse's station. And let's also teach their family members how to use the call light so that if a seizure happens while we're not in the room, they know how to call for help. And during a seizure, our job during a seizure, first of all, we're going to make note of the time that the seizure started. A lot of times that's a mental note because we're doing about 5 other things at the same time. But we want to be able to time the seizure so that we know how long did this patient go without oxygen, things like that. And we will document that at the end of the seizure. So make a note of the time that it started. Assist the patient safely to the floor if they're standing during a seizure. Remember, all of our interventions are literally cornered right around the idea of preventing injury, okay? So assist them to the floor safely, turn them to the side, their head and their body all the way to the side. Continuously monitor their airway patency, provide privacy. It can be embarrassing to have a seizure. So if there's any way we can pull a privacy curtain, shut a door, move them from a general area, we're going to do that if we can. Stay with them. The nurse is never going to leave. Remember, you are the nurse now. So there's no, I'm going to get help. You're going to tell someone to get help or you're going to call for help, but you are staying with your patient because now you're the nurse. We're going to, again, determine the time of onset. And then we're going to loosen any restrictive clothing. If they are wearing a super, super tight top, maybe around the neck, we want to make sure that we're removing that so that it's not so restrictive and cause them to decrease their breathing. And then move any hard objects out of the way to reduce harm. Here is a nice visual of just turning the patient to the side. So again, this is like your very first action. Turn them to the side to reduce that risk of injury here. So here are super, super, super important things for you to know not to do during a seizure. We are not ever going to attempt to open the mouth of a patient with a seizure. A lot of times their jaws are clenched and would be hard to open anyway. They're at high risk for biting their tongue, and you don't want your fingers in their mouth when they are clenched in that way. Do not ever insert anything into the mouth, such as a padded tongue blade. Nothing goes into their mouth when they're having a seizure. Do not try to restrict the clothing or control their movement during the seizure. Allow them to convulse the way that they need to. We just need to maintain their safety. That includes, we can put a pillow under their head. We can put a pillow around them, making sure that they have soft things to come in contact with and not hard things that may cause them harm. We cannot delegate the care of a patient having a seizure to an unlicensed assistive personnel. Nursing assessments are required during this entire process. We cannot leave our patient and we cannot delegate this. We cannot say, hey, tech, stay in here while this patient's having a seizure. I'm going to go call the doctor. It doesn't work like that. So that cannot be delegated. And what are we going to do about it after a seizure? So we're going to note the time that the seizure ended. We're going to keep our patient on their side until their airway is clear and the person is conscious. We are going to suction them if necessary. We are going to examine and assess for any injuries that may have happened during the seizure. And we're going to reorient the client. A lot of times they don't have any memory of the things leading up to the seizure and no memory of actually having the seizure. We're going to keep the lights dim. We're going to keep a calm environment. We're going to monitor their vital signs every 15 to 30 minutes for 2 hours afterwards. We're going to document that seizure. So we're going to document when it started, when it ended, the whole duration of that. We're going to document the location and the motor activity. So, what did you actually see? Were their arms and legs shaking? Was it just one side of their body? Was it just stiffening? Was it jerking? Were they crying out? Tachycardia? Did they have any aura? Were their pupils doing anything weird before? Dilated, constricted, anything like that? Unequal? So, those are all the things that we're going to document. And then afterwards, like we talked about the post-ictal stage, patients are very tired, lethargic, drowsy, and super confused afterwards. So we're going to allow them as much time to rest as they absolutely need to.